Hello class and welcome to week 1 of Kin 353. Dr. Ramos here. Today we're going to cover 4 different chapters. I want to start off by asking the question, what is an athletic trainer? We have some pictures here that the public may think an athletic trainer does. And to some degree we might do some of these depending on the setting that an athletic trainer works in. Traditionally, athletic trainers started working in collegiate settings and in pro sports, and they were typically equipment managers that would also help out taping the teams, and that evolved into a more diverse profession. Now athletic trainers can be found in a variety of settings, and for that matter, athletic trainers do more than just tape. We can also do a lot of rehabilitation, research, emergency response, just to name a few things. So as the profession has evolved, so has the education for athletic trainers. Injury care and management is still a staple of the athletic training education, but along with that, public health fundamentals has also become a part of that education due to the expanded populations that athletic trainers deal with now. Also, to provide quality care for the different populations that we deal with, it's become necessary to provide interventions that are based on empirical evidence. It has also become necessary to keep track of outcomes and modify interventions based on that. Once certified, these are the domains that an athletic trainer will be responsible for, and you can find more detail about this on the NATA website. Next, you may have heard the term evidence-based practice, and as it pertains to athletic training, that has become a big part of athletic training education and also practice. As it is listed here, when an athletic trainer is trying to choose a certain treatment or therapeutic exercise or some sort of intervention to treat his or her athletes, you would start by developing a clinical question, then searching the literature, appraising it, applying the evidence, and then assessing the outcomes. As you can see here, there's an acronym PICO, and just to give you an example of what that is, here's an example of a PICO question that I developed, and it was based on kinesiotaping as compared to regular or traditional athletic training taping. So this topic of evidence-based practice is really just a topic to hold athletic trainers accountable for what they're doing in the clinic and when they're treating patients, because you don't want to be a clinician that provides treatments or any type of intervention just based off of what your mentors or your preceptors said worked, without really verifying, is that the best intervention or best solution that I can provide for my athletes. Instead, athletic trainers are tasked to do some research, find out as much as possible about the intervention. In this case that I am presenting here is a kinesiotape, and then provide the intervention, compare it to the alternative, and record outcomes, and then decide, is this a good treatment for my athletes? Moving on to another important component of being an athletic trainer, which is the relationships that you build once you're a certified athletic trainer and you begin working a full-time position. As an athletic trainer, it is important to realize that even though you may be working in a setting where you're the only athletic trainer, you're not the only one that is responsible for the care of the student athletes or the patients. You will have to acknowledge and develop these relationships listed here, starting with the student athlete and the physicians, the coaches, parents, administrators, and any other specialty healthcare professionals. The importance of these relationships comes into play when you need a lot of background on the student athlete or the patient, so parents and the actual student athlete can be a big help there. Trying to get as much detailed medical history as possible is critical. There will also be many times where you have to refer to physicians, your team doctor, and other orthopedic specialists or even other medical specialists. And it's going to be important for you to build a good relationship with these other professionals so that they can give you a lot of information about their treatments, their diagnosis, and the faster you can get that information, the sooner you can make a return and play call. Overall, by nurturing these relationships, you'll become a much better athletic trainer because you'll be a lot more effective and efficient in giving care to your athletes or your patients. If you're interested in getting into the athletic training profession, you must get a lot more information of how to become certified as an athletic trainer, and that begins by learning about athletic training programs. On this slide, I give you some general overview of what's needed to be admitted into an athletic training program. And every program or every school is going to have different requirements. Here at the bottom, these are the CBU, Masters of Science in Athletic Training program requirements, where you need a 3.0 GPA, 3 letters of recommendation, 150 clinical observation hours, and then you also need to have certain prereqs, which will be changing in the next few years. So that's something that you have to make sure you're aware of by just checking the website. Moving on to the next few chapters, I'm not going to cover every single major topic covered in those chapters because you can read through that and then also look through the PowerPoint slides. But I am going to cover the more important topics that I feel you need to know, maybe a little bit more background about. So depending on what professional setting you end up in, you may or may not deal with hyperthermia, but I believe if you're going to be dealing with youth sports, anything like that, it's really important to know the signs and symptoms of when someone's dealing with any of these type of issues. So one of the biggest recommendations I can give to athletic trainers, coaches, parents is to make sure that you can prevent a heat illness, and that is mainly done through proper medical exam, so proper pre-participation examination to make sure that a physician can clear an athlete for full participation, that all the medical history has been looked over, and that we're aware of any, congenital conditions, any type of heart conditions that could affect the athlete through training. Next is acclimatization, which can really be taken care of within 7 to 14 days. So before, let's say, 2-a-day training camp begins, the athletes should be encouraged to start doing training on their own, which is something that at CBU, a lot of our coaches do a really good job of making sure that their athletes over the summer have some sort of training program so that when they come in for training camp, they're not starting from, day zero or a very unconditioned state. With athletics, even with the best preparation for intense training in high temperatures, you may still end up with people dealing with heat illnesses. So when that occurs, it's really important to be able to recognize and know how to treat those symptoms and to make sure that the athlete gets the proper care. On this slide, you can see the signs and symptoms of the most common heat illnesses and also how to treat them. And these are all taken from the position statement that the NATA put out. And I will upload that document onto your week 1 learning activities. So just look out for that, and that way you can have it. And it's a really good document to keep around, especially if you're going to be working with athletes. It's really useful because it gives you recommendations of how to treat things as simple as exercise associated muscle cramping, and also how to properly treat something as severe as an exertional heat stroke. But let's say if you don't remember all the details of each of these illnesses, you can't really go wrong with putting someone in a shaded area, removing any excess equipment or clothing, elevating their legs above their heart if needed, and then start cooling them down with ice towels or putting them in an ice bath and checking vitals. That's always very critical. But when it comes down to the most extreme illnesses, as noted here, which is heat exhaustion or heat stroke, you're going to need a little bit more sophisticated piece of equipment. So the difficulty in handling heat exhaustion and heat stroke is that the core body temperature gets to such a high degree that the blood circulating to the brain can start damaging cells and start killing them off. So it's important to reduce that core body temperature as quickly as possible. And that's why it's always recommended to put the athlete or the patient in an ice bath and start cooling their core body temperature down before they're even transported. As you can see here, it says transportation should not occur until core body temperature is below 102 degrees Fahrenheit. Another key figure to remember is 105 degrees, because that's what separates heat exhaustion and heat stroke. Someone that has a core body temperature of 104 and below would be recognized as heat exhaustion. Anything 105 or above would be considered heat stroke. The next part to this is, how do we most accurately measure core body temperature? And as I showed here, this piece of equipment here, that's a rectal probe that will attach to an instrument such as this, where it gives you a digital measurement of the core body temperature, but it has to be done rectally. And that's where it kind of becomes a problem, because not everyone can afford that piece of equipment, and not everyone is really trained to take rectal temperature. But as athletic trainers, it's becoming a part of one of the competencies that is required for athletic training students to be trained in. And that doesn't mean you will have to do it once you're certified, but you at least have to know how to do it in case of the institution that you work for has one of these thermometers. You're at least proficient in knowing how to use it. Moving on to musculoskeletal and nerve trauma. As an athletic trainer, you typically deal more with mechanical injuries, and it's important to know the tissue loading properties. So in your textbook, make sure to cover these topics: tension, compression, shearing, bending, and torsion. And also learning the difference between acute and chronic injuries, which can be categorized based on the initial injury, and then also the mechanism of the injury. This chapter, I'm not going to cover a lot of these topics. You can read about them, but what I did want to cover was stress fractures. The reason being is that it's not like a typical fracture where it's an acute injury. This is more of a chronic injury where it's due to overload, and as it describes in your textbook, it could be due to rhythmic, repetitive stress vibrations. These are typically seen in athletes that put a lot of repetitive stress on their joints, like long distance runners or even track, like high jumpers, such athletes as that. It's also very difficult to detect and diagnose because the athletes will be complaining of shin pain a lot of the times, and you're going to probably diagnose it as shin splints. But even when taken in for x-rays, it doesn't really show up. It doesn't show up until a few weeks after they've already sustained the stress fracture. And then it will show up as like a bump on an x-ray. Moving on to the tissue response to injury, specifically the tissue healing process. In this part of the lecture, we're going to go over the 3 phases of tissue healing. And those are the inflammatory response phase, the fibroblastic repair phase, and then finally the maturation and remodeling phase. As you can see, I noted the time frames for each of these phases. However, remember that the healing process is a continuum, meaning that the inflammatory and fibroblastic phases don't happen independently. They typically overlap, and the same with the maturation and remodeling phase. So let's start off with the inflammatory response phase. Some of the signs and symptoms. Um, these are the names of those signs in Latin, and they are redness, swelling, pain, warm to the touch, and then loss of function. So if you're evaluating a patient or an athlete and you see these signs, you're going to know that the body has responded to an injury. And it also means that the body is already healing itself. The important chemical mediators to note here and make sure that you read this a little bit more in depth in your book are histamine, leukotrienes, and cytokines. And they cause vasodilation, margination, and as it pertains to cytokines, they're the primary regulators of leukocytes and attract phagocytes. So all this to say that they make it easier for more fluid to enter the damaged tissue, and there's a reason for that. You do want some swelling there because then you have these, for example, leukocytes and phagocytes that help remove any damaged tissue, and that all takes a few days, but it's a necessary thing for the body to eventually start healing. In the fibroblastic repair phase, or fibroplasia, we have proliferative and regenerative activity, which leads to scar formation. So another name for this phase would be the scarring phase, because here we have the fibrin clot that was created in the inflammatory phase is broken down, and we develop granulation tissue. This granulation tissue is important because it's made up of fibroblasts, collagen, and capillaries, which are all the things that you need to make scar tissue. So the scar tissue is important because technically it's what is replacing the damaged tissue sustained from the injury. Now, the initial scar, if you're thinking about like a scab that you have over an abrasion, it's not the way it stays for the rest of the time. It will eventually mold and develop depending on what forces you place on it, which we'll get into in the next phase. But that's why this portion of tissue healing is really critical, and it's important not to disturb that process. In the maturation and remodeling phase, as I mentioned, we have the scar tissue being realigned based on the tensile forces applied. So it's what Wolff's Law says, like your body will adapt to whatever demands you place on it. So if you have a patient that is very sedentary, does not start doing range of motion and strengthening exercises at the appropriate time, that scar tissue from a surgery or an injury is not going to develop into the tissue that it's meant to be. For example, an ACL surgery, requires movement of that ACL eventually because you don't want it to be contracted and not have any flexibility in it. So as it states here, 3 weeks post-injury, you're going to have a firm, strong, and contracted non-vascular scar. And once that occurs, then you have this tissue that you can start molding. Like it says here, controlled mobilization and strength exercises are critical for proper tissue alignment. You don't want a scar tissue, for example, if you strain your Achilles tendon, you don't want it to remain contracted, as you're going to lose a lot of range of motion in your ankle, and you're also going to lose strength because it's not going to be able to contract and relax as your healthy Achilles tendon. So that's going to limit how much you can run, how much you can jump, and for athletes, that's crucial. You can see knowing the tissue healing process is very important for athletic trainers, but also for coaches and any other rehab specialist, because it dictates how the rehabilitation process is going to go. You don't want to jump the gun on any of those phases. You don't want to push the athlete too fast when they're coming back from a significant injury, but at the same time, you don't want to hold them back and keep them sedentary so much so that they're not ready to participate once most of the healing has occurred. So make sure that you read this portion of your chapter so that you understand it fully. And if you have any questions, any comments, please make sure to email me, or you can call me, and we can discuss this further. If anyone has questions, you can post it to the comment section under where we have our introduction section. So again, have a great week, and I will be talking to you guys later.